Hi, good evening, everyone. My name is Dr. Nikhil Sahasrabuddhe. I'm one of the neurosurgeons here at Riverside Community Hospital. And today I'm going to be talking to you about back pain. Specifically, we'll be talking about low back pain and some of the indications and advancements for spinal surgery. Some of the objectives that we're going to cover in this talk. We'll talk about the common causes of back pain. We'll talk about potential surgical treatment options with a focus on spinal fusions in particular. And then we'll have a discussion about some recent advancements in spinal surgery, including spinal navigation and robotic surgery, and what we're doing here at Riverside Community Hospital and how we're implementing these to better take care of our patients. So before we get into surgery, I think we should talk a little bit about back pain. And if you look at all people in the United States, 80% of people will at some point in their lifetime have back pain. And it is considered to be the leading cause of disability in the United States at this time. The two major categories of back pain are acute and chronic back pain. Acute back pain is very common, and this could range to a mild muscle spasm or a minor injury. The characteristic of acute low back pain is that most people have complete resolution of their symptoms, usually within a matter of days or weeks. And only a small percentage of people with acute back pain will eventually progress to what we call chronic back pain, which is pain that lasts for more than 6 weeks, up to more than 6 months. In terms of other types of back pain, not all back pain is the same in terms of how painful it feels to the person. One of the main types is called axial back pain. So this is a back pain that's constant, meaning it's always there. It doesn't matter if you're resting, it doesn't matter if you're walking, it doesn't matter if you're doing strenuous activity. There's always a constant level of pain that's always in the background. The opposite of that is something called mechanical back pain, which is back pain that is specific with movement of the back. So if I were to ask you to bend forwards or bend backwards, that would bring on your pain. But if you're resting, you have little or no pain. Other types of back pain, there's something called radicular back pain, which is specifically a type of pain that starts in the back, but then will travel down either one or both of your legs. The most common form of this is known as sciatica. And typically people will describe this as a sharp or a stabbing or an electric pain that shoots down the leg in a very particular way. And the last one is traumatic back pain. And this is going to be less of a focus, but this is pain associated with some sort of injury, like a fracture if someone's in a car accident or falls down the stairs. So before we go any further, I think it makes sense to talk a little bit about the basic anatomy of the spine. So this is a vertebral body, or one of the individual bones of the spine. And I like to think of it as one of the main building blocks of the spine. And what you see here is when you start to stack these bones on top of each other in a repeating fashion, you start to see the formation of the spinal column. And you'll see a repeating pattern. So if you start at the top there, the white structure is the main bone or the vertebral body. The blue area between each bone is known as the intervertebral disc, which is sort of like your body's natural shock absorber in the spine. Next down, you'll see a little yellow structure that comes off between each set of bones, and that's a nerve. At every level of the spine, you have a nerve that exits the spine to travel out into your body. And then down at the bottom, you'll see that between each bone, what connects one bone to the next is a series of joints. And when you combine all of this together, you get the complete spinal column, which looks like this. And if you look at the picture in the middle, you'll notice that the spine is not supposed to be a complete straight line. There's a curvature that is expected in a normal, healthy spine. And the other thing that you can imagine is if you have 30 plus bones put together with multiple joints, just like any other joint in the body, it's prone to developing arthritis. And a lot of times people will see this, and there's a lot of different names for it. People will be told that they have something called degenerative joint disease, or degenerative disc disease, or spondylosis. And these are all technical fancy terms for arthritis. So I think one of the main questions we have to dive into is, when should I see a doctor about my back pain? How do I know that this isn't just, something that's going to resolve on its own? And so there are some key symptoms that you have to be on the lookout for. One is one of the things we talked about earlier, which is that radicular pain, or that shooting pain that goes down the leg, okay? Another symptom is weakness in one or both of the legs. And specifically, not just a generalized weakness, but usually a weakness in one particular part of the leg. So maybe you're not able to lift the leg up as much as you normally used to. Or maybe when you walk, you find that you're dragging one foot versus the other. Another sign is the losing control of the function of your bladder or your bowel. This is more of a sign where you have to take with a little bit more caution. Typically, if a patient calls me and tells me that they're having problems controlling their bowel or their bladder, that's a sign that there may be some severe pressure on the nerves, and you may actually have to go to the emergency room for emergency treatment. And the last symptom is the inability to tolerate daily activities. So sometimes pain that may start off as a mild or dull or just annoying pain can get progressively worse and worse and worse until it gets to the point where you just can't tolerate it. And if that's the case, you need to see a doctor to make sure that there isn't anything serious going on, more than just a muscle spasm. And in general, the earlier you see your doctor, if you have a problem that actually requires surgery, the better. And the reason being is because you're not going to jump to see a spine surgeon right away. Usually what happens down the pathway is you're going to see your primary physician first. Based on your symptoms, if it's just pain, you'll probably be sent to physical therapy, potentially then to a pain management doctor. And there may be a series of therapies, injections or pain medications or other treatments. And then eventually you may get sent for an imaging study like a CAT scan or an MRI. And only then, if there's a finding, will we be sent to a spine surgeon. And that process can actually take several years. Most of the patients that I see with debilitating pain in my office, the reason they're in so much pain is because they've told me, well, I've had this pain for 5, 6, 7 years, and only now am I seeing someone. And they say, well, I waited 5 years to see my doctor because I thought I could just tough it out. I thought it would get better on its own. And unfortunately, by the time they see us, they have a bigger problem than maybe they would have had 5 or 6 years before. So if you experience any of these symptoms, I do encourage you to see your doctor earlier rather than later, and at least contact them to let them know if you need some more workup for this. So now that we've talked about what to look for, we should talk about why we operate on the spine. So we have a few major objectives when we're operating on the spine. One of the main objectives is to decompress any nerves that might be pinched. And this generally is the case when we talk about people who have symptoms of shooting pain down the legs or weakness or numbness, okay? The next major criteria is stabilization of the spine. So some people, the arthritis has gotten so bad that the bones will literally shift on top of each other. And instead of having a nice smooth alignment, you have bones that are pushed forward, bones that are pushed backwards, and that can cause significant pain, especially when you're moving. And we call that a potentially unstable spine, and that leads to that mechanical pain that we talked about earlier. And one of the last indications is to correct some sort of deformity. The most common deformity would be some sort of scoliosis. And again, scoliosis, a lot of people think that this is a disease that mostly affects younger people, juvenile or adult, adolescent scoliosis, but there is a form of adult scoliosis that is brought on by degenerative disease. So people can actually develop such significant arthritis in their spine that they actually start to develop scoliosis. And those are the people that you see where over the course of years they start to hunch over, they're starting to use a cane, they can't hold their head up. And sometimes those people need spinal fusions. So we'll talk a little bit about the nerve compression that I touched on earlier. So what you see here is a basic MRI. This is probably the most common study that I will see in my office on any given day. And what we're looking at here is a normal looking MRI. So what you see here, you'll see some dark gray squares, and in between you'll see some light gray. They almost look like flattened footballs. And that's your stack of disc and bone that goes all the way up. What you should notice here is that there is a smooth transition from one bone to the next bone and the disc in between. Everything is lined up very well on top of each other. And the white space behind it is the spinal canal with the spinal fluid and the nerves floating in it. So we like to see a large area of that white space. Okay. So here's an abnormal looking spine. Okay. I'm going to flip back really quick so if you can compare what a normal one looks like and what an abnormal one looks like. You can see right off the bat that you have multiple bones that are slipped relative to one another. Some are shifted back, some are shifted forward. You see those discs that are in between those bones. Some are flat, some are angulated. And then you see where that nice white open space behind the bone should be. It looks very dark and hazy, where you can barely make out the nerves. And this is a condition called spinal stenosis. Stenosis is just a fancy word for saying pinching or tightness. Here's another very focal area. You'll see here that for the most part, the spine looks healthy, but down here towards the bottom, you'll see that there's a giant black ball sitting behind one of the discs. And this is what's commonly known as a herniated or a slip disc. People who have this usually complain of severe back pain, but mostly going down into the legs. And the treatment for this condition is to remove that pressure by something called a microdiscectomy, as opposed to the previous, where you have to do a more extensive removal of bone to get the pressure removed. So the next question to answer is, why do we fuse the spine? So what patients require fusions, and what patients only need pressure taken off the nerves? Okay, and the main reason we fuse the spine is to stabilize the spine. So here are two different MRIs. The one on the left is the one that I showed you earlier with that large herniated disc. And then there's one on the right that looks fairly similar with another herniated disc. And these are two separate patients that were treated in two different ways. The patient on the left had a little bit of back pain, but mostly leg pain shooting down into the legs where she couldn't walk. And this patient was treated with a microdiscectomy. No fusion was needed. The patient on the right not only had severe pain going into the legs, but also had severe debilitating back pain that was worsened with any sort of motion, to the point where he was unable to walk and get out of bed. So why the difference? Why is there such a disparity between these two patients when the scans don't look all that different? And the answer is, well, we need more information. So in a patient like this, we get a CAT scan. And here's a zoomed in view of the CAT scan. And a CAT scan is good for looking at the bone specifically. MRI is something that we use to look at the nerves and the discs and the soft tissue. But for a better understanding of the bone, we look at a CAT scan. And if you can see where those arrows are pointing, we found that this patient had these breaks in the bone on the back, something that he was likely born with but didn't become an issue until he became older and started to deal with arthritis. And what happens when you develop breaks in the bone is you develop what we call mechanical instability. So what happens is, I'm going to use this 3D model now. When you look at your spine is supposed to be able to flex and extend backwards and forwards. That's how we're able to bend backwards and forwards. But if you develop a break in the bone in the back, which is what this patient had right around here, instead of a normal flexion like this, you start to get this. And you get this abnormal motion of the spine that's not supposed to be there. And when that happens, that can cause severe debilitating pain. And that's the kind of patient that needs a spinal fusion. So now we're going to talk a little bit more about what spinal fusion actually means. What are we actually doing in the operating room when we treat you with a spinal fusion? The most common form of spinal fusion is something called pedicle screw fixation. And quite literally, it's a construct of a pair of screws in each bone, and each row of screws is connected by a rod. And these are usually made out of titanium. And what this does is this acts as a scaffold to hold your spine in its correct alignment so that it no longer moves in a way that is abnormal and potentially dangerous. In terms of how we put these screws in, this is sort of a top-down view of that bone. As you can imagine, putting a screw in the spine is a very delicate ordeal. It's sort of like carpentry on the spine, but we have to be a lot safer than when we're putting a standard nail into a door, okay? So if you consider what the other structures are around the spine, we have to make sure that we stay away from the spinal canal, where the nerves in the spinal cord are. We need to make sure that we stay away from all the individual nerves that come out at every segment of the spine that I showed you before. And we need to make sure that we're not coming near any of the other structures that are around the spine. You have large blood vessels, you have muscles, you have your organs of the abdominal cavity. So all of these are, potentially things that we have to look out for when we're putting these screws in. It's a busy diagram, but what I want you to focus on is the top left corner. That is the way a screw should look. So it's sitting within the confines of the bone. If you look at the majority of the other squares, these are all ways that a screw can be placed the wrong way. Because if you look at screws can be placed too much towards the middle of your spine, too close to the nerves, or too close to the outside where it's not even sitting in the bone. They can be placed too high, they can be placed too low. And any one of these has its own problem, whether it's a weak screw, pinching of a nerve, or injuring another part of the body. So placement of the screw is critical and paramount when we're doing these spinal fusions. So again, just to touch base, the risk of a misplaced screw, we're talking about nerve damage, a weak screw that doesn't actually do its job, disrupting the normal bone that's supposed to be around it, any healthy joints, and injury to any major blood vessels or the bowel. And so how do we place a screw? So the evolution of screw placement, when spinal fusion first started, we had what we called the freehand technique, which was basically memorizing all the spots where the screws are supposed to go and putting them in on our own based on feel. No one really does it this way these days. Most people will use X-ray guidance, so taking multiple pictures while we're putting the screws in to guide our process. But this can sometimes be a little bit more time-consuming and require a lot of radiation with multiple X-rays. So the new advent within the last decade, which is slowly becoming the norm, I would say, is spinal navigation, and then the step up from that is robotic surgery. And that's what we're starting to do here more and more at Riverside Community Hospital, as we've invested heavily in this technology to really stay at the forefront. So we have a question here. Are there any risks associated with robotic spine surgery? So that's a good question. Like any surgery, there are still risks involved. There's no surgery that I can say is completely risk-free. But the advantage of robotic spine surgery is that it dramatically reduces those risks that we talked about. So what the robot helps us do, and I'll explain this in just a few moments, is that it really increases our level of accuracy for all of the screws that we place, such that we can lower that risk, not to zero, but as close to zero as it can possibly be. So I'm going to touch on spinal navigation first. And I like to call this spine GPS. It's a GPS for your body that allows us to navigate anywhere we are in your spine. It allows for more accurate placement of our screws, reduces injury to other structures, reduces our complication rate. And what it also does is that it allows us to better plan our surgery before we even start. So with navigation, I can look at every single bone that I'm operating on. I can look at the size of the screw that I want to place, the location where I want to start, the location where I want that screw to end, and how I want all those screws to line up when I'm done so that everything lines up perfectly. So here at Riverside Community Hospital, this is just a snapshot of some of the technology that we started using recently. I'll touch a little bit more. So the first thing is the intraoperative CT, or the O-arm. And quite literally what we do is, after the patient is already on the table and they've been anesthetized and positioned, we will bring this portable CT scanner into the room that starts off as a C shape and then closes around the patient, and then we can scan any part of the body that we choose. Once this scan is done, it gets linked to a GPS computer, which registers to each patient's own body, and quite literally I can take a pointer and place it anywhere on the spine, and it will tell me exactly where I am in real time in that patient's body. So I can confirm that where I think the screw is supposed to go is actually the correct place. The next step forward from this is the robotic arm. So this is a structure that's actually rigidly fixed to the operating room table. It doesn't slide. So its position relative to the patient never changes. And this actually links into the spinal navigation and the intraoperative CT that we're already using. And instead of just telling me where I am, this actually tells me where I'm supposed to go. So what I will do when I'm using this robot is, before I even touch the patient, after we get the scan, I'll go to the computer first. I'm going to plan every single screw, the trajectory, the starting point, the ending point, the size of the screw, and that all gets pre-programmed into this arm. And the arm will actually set itself in position. I'll say, okay, I'm ready to place screw number 1. And we program that into the robot arm, and it automatically goes down and angles itself. So it takes any guesswork out. The robot that we're using here at Riverside Community Hospital is called the Mazor X. And what you can see here on these two images on the right, the bottom image is the robot arm in place with the screw driver being guided through the guide. And at the same time, what the surgeon is doing is looking at that top screen, and it will show you virtually in real time where that screw is actually going, how far it has been placed, and how much further you need to go to get it to exactly where you want to go. And where this really takes advantage is in minimally invasive spine surgery, specifically minimally invasive placement of screws. So for patients that are typically getting multi-level spinal fusions, the more traditional way is a large incision down the middle of your back, exposing all of the muscles and pushing them out of the way until you finally make your way down onto the spinal column, and then placing of the screws, followed by closing everything back up. And as you can imagine, making a very large incision and moving all the muscle around is painful. And this red line across the back is what a typical open procedure would look like, how that open incision would look. So you're talking about an incision that's several inches, 6 to 10 inches long, to put in this many screws, 5 screws on each side. Whereas if you see the minimally invasive approach, which we're looking at here, you're talking about a small 1 to 1.5 centimeter incision per screw, okay? But not only that, instead of opening up all that muscle, you're sliding between the muscles for each screw. So you're talking about much less pain post-operatively. So the overall benefits of spinal navigation, less muscle exposure and dissection, which leads to less post-surgical pain, less blood loss because we're making smaller incisions, shorter operating times because we're not making large incisions. We don't have a large incision to open and close. And we don't have to do as many interval x-rays. And the shorter operating time actually leads to a lower infection rate. So you have lower risk in terms of developing a wound infection that potentially needs to be cleaned out. As we talked about before, spinal navigation allows us to lower the chance of any nerve injury. And all of these things combined mean that you can spend less time in the hospital. A shorter hospital stay means that you can go home faster. So in conclusion, spinal fusion is indicated for patients who have not only nerve compression, but some sort of deformity or instability of the spine. Spinal navigation and robotics allow for more accurate screw placement and easier minimally invasive surgery, and in the end, this leads to less pain and a quicker recovery. And this is what we've been doing at Riverside Community Hospital. This is the technology that we've invested heavily in, and this is where we see the future of spine surgery going as the standard forward. Thank you very much. Okay, great. So we have another question. Are the screws titanium? Yes. So the standard for screws these days are titanium. In the past, spinal fusion, if you were to have a spinal fusion 20 or 30 years ago, you may have stainless steel screws and rods and hooks. That is no longer the standard of care. The main reason is because stainless steel is not MRI compatible. After you have a stainless steel rod put in, you can no longer have another MRI. Titanium is MRI compatible, meaning after spinal fusion, you can still go and get an MRI if you need it. The other main reason is titanium, and the other versions of titanium that we have, they're stronger, and they provide a more rigid, stable construct with less chance of breaking. Another question coming in. Have you seen a link in spine or back issues with people, maybe younger, staring down at their phones so much? Okay, so that is a good question. We do, unfortunately, myself included, in this digital age, we do find ourselves staring at our phones quite often, or in front of a computer chair for that, in front of a computer on your desk. And in terms of people developing issues from on the phone, basically in this position for hours on end, most people will develop some neck pain, okay? Generally, in the younger population, because you're young and healthy, you don't have a lot of arthritis, so it mostly appears with muscle spasm, neck tension, things like that, which will typically get better with massage or stretching. In the older population, say 50 years and above, people will already have some form of arthritis in their spine. And repetitive positioning like this can actually worsen the arthritis that's already there and bring on spinal disease faster that may need surgery. And if you look at people who are on a computer all day, if you don't maintain appropriate posture at your chair and you're sort of hunched over doing this, that typically leads to low back pain. And the same rule applies. If you already have arthritis in your spine, that will likely exacerbate it and potentially advance the arthritis that you already have and lead to a problem down the road. Yes. Is there such a thing as being too old or too young for spine surgery? As a general rule of thumb, the younger you are, the more we try to avoid fusing your spine, okay? Because you have potentially many, many more years to develop some long-term issues from a spinal fusion. But the answer is, if you need a spinal fusion, you need a spinal fusion. So what does that mean? If you have any true spinal deformity that causes debilitating back pain, or spinal instability where your bones are literally just shifting over each other, at that point it doesn't matter how old you are, it's a surgery that you need. What we do know from spine fusions is that in a percentage of the population, 5 to 10%, people who get spinal fusions 5-10 years down the road may need further surgery. And the reason being, once again, if you look at the way the spine is supposed to be, it's not a rigid structure. It's actually supposed to be a mobile structure. And when we do a spinal fusion, we now take an immobile segment and we've fixed it, okay? And that not only includes the joints, but that includes the function of the shock-absorbing discs. So over a period of time, if we've now fixed one segment, it's no longer able to absorb some of the shock that it used to be able to. And the areas above and below have to do a little bit extra work to pick up the slack. And in some patients, that can actually lead to more degeneration. So while spinal fusions are sometimes necessary, we do have to take that into account. What are the chances that a given patient will have breakdown in the future because of the spinal fusion and need more surgery? How do I know if minimally invasive spine surgery is right for me? That's a good question. So obviously minimally invasive spine surgery is the more appealing of the two when you compare it to open spine surgery. And I would say that anyone who's being considered for spinal surgery should be evaluated by that spine surgeon to see if a minimally invasive approach is feasible, if it can actually be done. Sometimes the nature of the problem with the spine can't be done through a small tube, and you need an open approach. But as our technology improves, specifically with spinal navigation and robotics, our ability to access any part of the spine is easier now than it ever was. So I would say that not all patients, but the majority of patients are potential candidates for minimally invasive spine surgery. Do we have any other questions? Okay. I guess we have one more. Can I find more information? Yes, you can find more information. So if anyone has more questions about minimally invasive spine surgery, spinal navigation, robotic surgery, all this information can be found on the Riverside Community Hospital website, where you can learn more about these techniques, what we're able to offer you here, as well as more information on our neuroscience department. And hopefully those can answer your questions. Okay. Thank you very much. I hope this was informative, and I look forward to treating any of you out there who need help. Take care.